This is Dr. Sakhnini speaking, greeting you and welcoming you to the new video that talks about neuroma of the superficial radial nerve. This is a young patient who was treated elsewhere with the suturing of a nerve in his forearm. Now he has pain, excruciating pain, he's on narcotics, he has lost function of his hand. So as we saw that the symptoms are nerve symptoms that come with a positive TNL sign, we opted for surgical resolution. This is the incision that we had in order to incorporate a prior scar incision. So this is a volar radial approach. We incorporated the scar of the prior surgery and went distally and proximally in order to find a healthy nerve and then try to find what happens in the zone of injury. After hemostasis, the second stage is to raise the flaps of the wound and to discern what structures are inflicted with the scar and with the injury. This patient for a long time had no full function of his hand with pains, especially in the night. Already mentioned the positive TNL sign. And we knew that there would be a neuroma, but what kind of a neuroma? Will it be continuous? Will there be a heavy scar tissue? Now we get further in the exploration and dissection of the surgical wound, and we can see that there is a large and heavy scar tissue in the zone of injury that is make it a little bit difficult to elevate the skin flaps. It's important to find anatomical markers and anatomical structure that helps with the surgery. So at this stage we did a distal extension of the wound, and we found a healthy nerve, a healthy branch. So we have to see if it is incorporated in the scar or in the main, or it is sutured or not. So the main work here, or the hard work here, is to work on the scar and to take out the nerves from the scar tissue. We can find that there is a cephalic vein here. Cephalic vein is a good marker, as we know that the radial or the sensory branches of the radial nerve goes along with the cephalic vein. And also there is the brachioradialis tendon, which also is a good indicator, as the superficial radial nerve cross volarly on the brachioradialis. At this stage we can find the two sides of the nerve. We put a visual loop around it, and then we continue to work and try to meet in the middle. What happens in the middle? We see that the nerve is stuck with a heavy scar tissue to the brachioradialis and the surrounding soft tissue. So at this stage we are trying to externally neuralize the superficial radial nerve from the surrounding scar tissue. We can see here the brachioradialis beneath the nerve, and it is really stuck to it. This actually explains part of the pain that the patient had. So now we raised the nerve from the tendon. The next question that we have to ask ourselves: what kind of neuroma is it? Is it a neuroma in continuity? As we can see here, once we trim and debride the scarring around the nerve, that this is a neuroma in continuity, and as such we will not excise it. We will only debride it and clean it. We don't have a large bulb around it, it's only a scar, so we lift it without excision. What we found also is a distal branch of the superficial radial nerve embedded in a scar. we trim it. Look at the scar, it looks grossly as a neuroma. And now we have a nerve that is not lacerated, but is not connected to the main branch. And the idea is to reconstruct it with end to side fashion, in an end to side fashion, where the distal branch, we will incorporate it in the main branch. We took out the scarring, we did more trimming and more cleaning in order to have fresh ends. We opened the epineuron of the main branch and surround it with a protector in order to help eventually with preventing scarring at the same place. And now technically we go and do the suturing in an end to side fashion of the distal branch that is lacerated and was found incorporated in a scar tissue and was not sutured to the nerve. And then we do another end to side suturing. It looks like a Y at this stage after we open the epineuron, of course. This will help reanimate the sensory sensation to the hand also. And a very important point to make is that it will help also with the pain, as there will be no free loose ends. And after suturing we will slide the neurogen distally, and this will help make a wall between the nerve and even the suturing of the nerves and the surrounding tissue in order to fight back against any positive Tinel sign to this injury. Now after suturing we slide down. You see that this is free, but we could slide it, and this will cover the whole zone injury of the radial nerve and even the part where we did the suture. And we close it with a running 4/0 rapid vehicle suture. And even we dock it, we try to put it to the epineuron here in order not to slide back, to make its position permanent, so that it will continue to protect this area and will not slide proximally. So in order to summarize what we have done, we can say that every surgery is different. Every surgery for trying to treat neuroma is different. One important part of treating neuroma also is to do a neurolysis of other potential point of pressure. This is why at this stage we opened the proximal tunnel for the superficial radial nerve, where it crosses between the brachioradialis and ECRL, where there's a very tight tunnel that is sometimes could cause Wartenberg syndrome, for example. So we did a preemptive measure to neuralize it. It's very important to neuralize a nerve that is incorporated in a scar or in a neuroma or part of a pain syndrome. After that we close the wound with the 4/0 rapid vehicle suture in a continuous manner. Now let's talk about the endpoint or the outcome. This is the patient 2 to 3 weeks following the injury. He is doing flexion extension with his wrist and digit. Something that he did not before. The zone of area is not sensitive anymore. There is no positive Tinel sign. So it's very promising. Thank you.